Behavioral and Community Health Sciences here at the University of Pittsburgh Graduate School of Public Health. She's also an affiliate member of the Center for Health Equity and the Geoinformatics Laboratory. Dr. Mendez completed her postdoctoral training as a Kellogg Health Scholar. It's a very coveted scholar program, if you don't know it, and earned her MPH and PhD in maternal and child health, focused in epidemiology at the University of North Carolina at Chapel Hill, and her bachelor's in sociology, anthropology, and pre-med track at Spelman College. She's a social and perinatal epidemiologist who applies a variety of methods and approaches in her research related to the complex intersections between stress, racism, place, and context as key in understanding the racial/ethnic inequities in pregnancy, birth, and women's health outcomes. She also currently serves as an executive member and research lead of the Infant Mortality Collaborative for Allegheny County, a member of the Pennsylvania Maternal Mortality Review Committee, and advisory board member for Women Engaged, an organization dedicated to improving women's health and advancing reproductive justice. It's really my pleasure to introduce
the introduction and this opportunity to present some of the work that I've been doing over the past, let's say, decade or more. So as you see from my title, I'm planning to address race, racism, and inequity. To address that in one lecture is quite a bit, so I'm just going to give you pieces of some of the work and scholarship nationally on this issue, as well as some of the work that I've been engaged in. I consider myself an anti-racist scholar and attempt to use anti-racist scholarship and approaches to address the work of addressing health disparities and population health. And that it's important to consider the larger context with respect to the research and the work that we do. So as I mentioned, today I'm going to talk about race, like what is race, how do we measure it, what are racial differences in maternal and infant health, racism as a determinant of health with examples in maternal child health and sexual reproductive health, and then some of my own ongoing research and works in progress. So my presentation will actually focus on the experiences of Black Americans as well as Black-white disparities, although I acknowledge that historically marginalized populations have been affected by oppression and racism that have implications for health as well. So just a quick public service announcement. As I mentioned, I'm just touching on pieces of all of this. You can get more this fall if you like. So for the students, there is a social epi course that I teach with Dr. Fabio. It's on Friday. We attempted to move the day because Friday afternoon is a little difficult. So I relay that to you as an opportunity to learn more about these issues, this research, and these concepts. So what is race? So most public health researchers have been involved or conducted studies that have included race. So can I just see a show of hands of folks in the room who've done any work related to race? Racial differences, control for race is a covariate, racial equity, community organizing. Let me see. All right, so look around, most of you, right? So how is race defined, conceptualized, and measured? So based on a narrative review on structural racism in health by Bailey, there's over 47,000 peer-reviewed articles that focus on race and health, right? So that's quite a bit. So what is race? Race has emerged as a social political construct useful not only to classify human variation, but also to justify the exploitation of groups defined as inferior. So if we talk about the historical context of race and why it was developed as a means to determine that those of African descent were less than, innately inferior compared to white Americans. And this was used to justify slavery at the time. At the same time, you had researchers and physicians who were conducting scientific research, if you will, to classify humans, right? To reinforce white supremacy and anti-Black racism. Race is not a genetic or biologic construct, although this is an issue that we still talk about in the medical sciences. And even the Human Genome Project has shown that race has no genetic basis, right? So, I mean, I spent a whole lecture just on this. I don't have time to do that, but we can talk further at the question and answer if anyone wants to talk more. So if there's no biologic basis for race, why do we even measure race or investigate racial differences in health, right? So this conversation around, well, why even measure it, right? This conversation was actually quite prominent in Brazil for quite some time as well. But it's safe to assume that eliminating the measurement of race, right, how we construct it, will not erase the racial differences that we see or the inequities. And if race is a social construct, it's capturing inequities and injustice, including power and status differentials that exist between racial groups. So how the policies, societal arrangements, position status and opportunities are shown throughout our history in the United States. Also, it's legislatively mandated that we measure this, right? This is an attempt to monitor the social and economic progress of population groups that have experienced differential treatment according to their race throughout history. Right, so the Office of Management and Budget have their revised guidelines. So this is basically what most of you are familiar with, right? These are the minimum categories used in the census. You probably see them in your studies that you're involved in. Obviously, you know, those conducting studies may expand these categories, add additional elements, but these are the minimum 5. Right, so there are considerations of revising this, even with the most recent census. There was quite a amount of pushback for the administration and the decade of work that was done to revise these was undone recently. There's actually a conference this week, and I'm attending that's discussing this issue. So we have the categories you're familiar with: American Indian, Alaska Native, Asian, Black or African American, Native Hawaiian, other Pacific Islander, and white, and then 2 ethnicity categories of Hispanic, Latino, or not. You may also see other ways in which race is measured in your own studies or in studies that you've read. So in addition to self-identified race and ethnicity of the country of origin, length of residence, there's also studies that have looked at research or clinician observed race, and then socially assigned race. So Kamara Jones, who I'll mention a little bit more about her work, asked this question in one of the modules for BRFSS, you know, your self-identity, but then also what others would identify you as, right, if they were to just see you. Okay. So we have enduring racial disparities in maternal and infant health, which we would consider tier 1, right? We're very great at looking at descriptives of racial differences in outcomes, various types of health outcomes, right? So I'll show you some examples of this nationally and locally here at Allegheny County. And the contributors to these disparities are complex. So I want to first talk a little bit about some of the common risk factors that we typically see in the literature, which would be considered tier 2. And then I want to kind of revisit how we think about this, which is tier 4, based on critical race theory and public health critical race practice. That really is based on the foundation that elements of our history of racial oppression and racism are key in our understanding of why disparities exist and the disparities that we see among populations. I'll have limited time to talk about tier 3, so I won't go into detail on that, but just cite a couple examples at the very end. So although, as I mentioned, there's a history of oppression and racial formation and disparities that affect multiple populations, I focus primarily on people of African descent. So infant mortality is an indicator of the health of a nation, and according to data generated by the Organization of Economic Cooperation and Development, the U.S. ranks 33rd out of 44 with an overall infant mortality rate of 5.9 deaths per 1,000 live births. We also see a disparity, right? So this is a disparity for the United States, where Black women are more than 2 times as likely to have an infant death compared to white women. And that disparity is even more stark in our own state. So this shows variation by other racial and ethnic groups. We see that there has been a decline in infant mortality in general between 2005 and 2013. But we see that, once again, African Americans or non-Hispanic Blacks have the highest rates. We also see rates that are higher than whites among American Indian, Alaskan Natives, Puerto Ricans as well. This is data for Allegheny County. Here I present the death of an infant within the first year of life, infant mortality per 1,000 live births. And here in our county, we also see a disparity of close to 3 times. We also see racial disparities in preterm birth, which is less than 37 weeks gestation, low birth weight, and what's even more stark is maternal mortality. Right? I think a lot of times we're used to seeing these disparities, but I want you to kind of sink in on what you're seeing on this graph and what that could potentially mean. So maternal death of 4 times in our county. Other outcomes related to maternal health, pregnancy-related weight. Black women are actually more likely to not gain a sufficient amount of weight during pregnancy and are more likely to be obese prior to pregnancy. And then finally, there's been quite an amount of work recently on maternal mortality, as I showed earlier, but also morbidity. So for every 1 death, there's thousands of near misses or severe morbidity. This is among hospital deliveries. And once again, we see stark disparities, but also an increase in morbidity over time. Right. So why do these inequities exist, right? So I talk about like the usual suspects, like these individual risk factors that we might consider as important for understanding health risk among populations and potentially disparities, right? So these individual risk factors don't necessarily explain the disparity. So I want to show a few examples of that. So the first is educational attainment. So I show this older graph because there's been some changes in the ways in which we assess and collect educational attainment and birth records. And as we see with higher levels of education, there's a decrease in preterm birth among all racial groups. But what you'll notice is that white women with less than a high school diploma actually have a lower rate of preterm birth compared to white or black women with more than a high school education. And I'll break this down a little bit, but this is some of the ways in which this data was collected. So this report, developed by Duke University, looked at US births linked with infant deaths. And this was based on data from 2013. And they looked at disparities comparing black, non-Hispanic black women and non-Hispanic white women by education level. And in this analysis, they actually adjusted for age and marital status. And what we see is disparity at each level, and that disparity actually increases with increasing level of education. I think this is a very unexpected relationship that many in the field or outside of the field may not necessarily recognize or know. About student actually conducting specific work among college-educated women, comparing black and white women, black women specifically in their particular experiences with workplace discrimination as a key factor that may explain this disparity that we see. So what does this look like in Allegheny County? This is unadjusted for some of the other factors from that Duke report. Once again, disparity remains. We do see a decrease in preterm birth for black and white women with increasing education. And then what about prenatal care, right? Another common risk factor with relation to birth outcomes or pregnancy outcomes. So what we see is that the highest rate obviously is among women with no prenatal care at all. Part of the argument here is that women who are not able to access prenatal care have additional risk factors that are affecting their lives. But we see a disparity at each level of entry into prenatal care as well. Considerable amount of work has also been done around nationality and country of origin. And this graph in particular shows among women who were US born versus foreign born, the rates of infant mortality. So among black women born in the United States, they have the highest rates compared to black women born elsewhere. We see the same relationship among Asian and Pacific Islanders. Puerto Rican women, it's really hard to kind of characterize in this way because Puerto Rico is Commonwealth of the United States. We also see this relationship among Mexican women as well. Jimmy Collins, scholar in Illinois, has done considerable work looking at the relationship between foreign-born status and generational health disparities in low birth weight, showing that for each generation among African-born women compared to African women, that there's an increase in low birth weight for each generation. So one other example, we could think about, another intervention outside of prenatal care, perhaps SIDS, the Back to Sleep campaign, which was very prominent in the United States as a means to address SIDS-related deaths. We see in general this decrease in SIDS-related deaths over time. However, the disparity remains once again, right? So same picture. Pre-pregnancy BMI, right? We may consider weight, but weight be important for addressing the disparity or explaining part of the disparity. And we see the disparity remains. Among white women, there is a slight increase in preterm birth with each level, comparing normal weight versus obese and overweight and obese classes. However, that disparity remains, and we don't see much of a change among Black women. So why do these disparities exist? Just to revisit this kind of tier 2. So our narrative in the United States around health, and particularly health disparities, has been, well, if that individual would change this, or these individual risk factors are critical and important, without a larger conversation about the context in which women live in those circumstances and conditions that shape their lives. So prominent researcher Diane Rowley, in her work around racism and preterm birth, sort of turned that on the head to say, well, what is unique about the experiences of that particular group? What is the social experience? What is that dynamic? What is the larger context that's affecting their lives? Right, so it's shifting that conversation from individual focused behavior, individual blaming, to what are the larger systems and institutions that could be potentially affecting them. Right? So it brings us to this larger conversation around maternal infant health that we've seen in the media as well. So some of you may be familiar with the ProPublica series, Lost Mothers, that have focused on maternal mortality in the United States, where they interviewed over 60 family members of women who died as a result of maternal issues, maternal pregnancy issues and complications. This first story is one of the first that came out publicly around this issue of maternal mortality within the Lost Mothers series, Shalon Irving. She was actually a fellow Kellogg scholar in the same cohort as me and passed. And one of the sort of larger conversations was, this is a woman who did work on maternal and infant health. She was a CDC officer. She had access to resources. What were the larger contexts that affected her life, even as a woman with access and opportunity? Many of you may also be familiar with Serena Williams' op-ed and some of the things that she wrote about her experiences with almost near miss or life-threatening experience during her pregnancy and not being heard, right? Talking with the doctors, with the nurses. These are the issues that I'm dealing with and not being heard. And so these conversations in the media obviously opened this larger conversation around what are the experiences of women, particularly Black women, with respect to their encounters within the healthcare system and then their larger maternal and infant health outcomes. So with that, why discuss or study race? As I mentioned, race is a social construct, but it precisely captures the impact of racism. And I'll talk about what I mean when I say racism. So it measures a social classification of people in a race-conscious society, right? So I know we talk a lot about colorblind, and we don't see color, but we live in a race-conscious society where racism and racial oppression is a core element of our history, meaning that it's deeply ingrained, and it's a part of both our historical and contemporary impact. So this also stemming from critical race theory and public health critical race praxis. And it's hypothesized that racism is a fundamental cause of racial disparities of health and is central to our understanding in eliminating those disparities. So Kamara Jones has done quite a bit of work on articulating racism and using both storytelling and allegories to explain the ways in which racism manifests, but also how it could potentially impact health. So she has what's called the Gardener's Tale. You can read a little bit more of the citation. She also sort of presents it and walks through this story as well. And so what is racism? Racism is a system. A lot of times we think about, well, I went here and this person treated me this particular way. And I'll talk about personally mediated and what that means. But in terms of racism, it's a larger system, structuring opportunity and assigning value based on the social interpretation of race, where it unfairly disadvantages some individuals and communities and unfairly disadvantages some individuals and communities. And there are 3 levels that she talks about: institutionalized, personally mediated, and internalized. So with institutionalized, we're talking about, right, institutions, policies, laws that are codified, right, addresses the fact that there's differences in goods, services, and opportunities based on race, right? So although institutional racism is arguably the most important mechanism that could affect health, it's challenging to really capture in traditional epidemiologic research, and it's hard to quantify, right? So although researchers, epidemiologists have attempted to quantify and measure institutional racism, it's quite difficult. So when we think about institutional racism, however, I think it's important that we also consider the historical context, right? So anti-racist scholarship is really, it's really pertinent that history is a core component of the ways in which we address health issues, right? So I don't have time to go through all the details of this, but we think about 1619, this marks the 400-year anniversary, where multiple schools of public health are commemorating the arrival of enslaved people in Jamestown. And this history or this timeline shows both the legally sanctioned aspects that have affected people of African descent, as well as those that are particular issues that were happening at the time that may not have been legally sanctioned but were supported by state, right? So we talk about within the context of sexual reproductive health, right, legally sanctioned reproductive and sexual violence against women who were enslaved. Lynching as well as one example. Medical experimentation, many of you may be familiar with Harriet Washington's work on this. Laws prohibiting formal education and then limited educational opportunities, even with the advent of Brown versus Board of Education. We see the same in housing, even with the advent of the Fair Housing Act of 1968, right? So we can go on and on. So residential segregation, however, has been the main ways in which health researchers have attempted to articulate the ways in which institutional racism may impact health, with a focus on place-based or geographic issues with respect to institutional racism. Residential redlining, also linked to segregation, is some of the work that has also attempted to look at specific ways in which laws and policies have been codified and have potentially affected both health, but also work through residential segregation. Right, so redlining is one term that was coined that describes the ways in which mortgage lenders would figuratively draw lines around minority communities and refuse to make mortgage loans within those areas. And it has a historic and contemporary component to it. And I'll give an example of that. There's also subprime lending, which we saw more recently around 2004 to 2008 during our housing crisis, where Black and Latino zip codes were specifically targeted by banks and mortgage companies. And we saw market loss in home equity disproportionately among communities of color. We can also talk about food pricing, or food lining, medical redlining, incarceration, prison industrial complex, that despite similar use of drug use, African Americans and Hispanic individuals are more likely to be sentenced and get jail time for that use, and then immigration policy as well. So some of my earlier work around institutional racism and redlining was an attempt to understand how the ways in which mortgage discrimination and segregation may work through a pathway to create adverse outcomes related to preterm birth through potential stress pathways. And so in this work, we created a new measure of redlining using Home Mortgage Disclosure Act data. And this includes all lending in the United States. Our particular geographic region was Philadelphia County from 1994 to 2004. And this includes loan level, individual loan level data for a particular region. The smallest geographic unit available within the HMDA is the census tract, right? So you have the opportunity to create, in our case, a composite measure of redlining or mortgage discrimination. So what we did is we included this data to create a composite measure of loan denial on the census tract level after taking into account multiple individual level factors that would be important for why a loan may or may not be denied. This is an example of a historical map, right? So this is considered the Homeowners Loan Corporation map for Philadelphia, just to give you a little bit of context. So when I mentioned redlining and sort of the mapping and the drawing of the lines, this is what was used among both lending institutions and banks. And those that were marked as red were considered hazardous, were not able to receive loans in those areas, and they were also areas that were predominantly African American and in some cases more recent immigrant populations at the time were also coded red. This is an example of what this looks like in Pittsburgh, and I'll mention at the end we're conducting some new work around redlining here in our county and across the state. We'll have the ability to sort of map and look at the relationship between contemporary disparities and this redlining map over time. And so in our analysis, and this is just really brief, but essentially we wanted to look at the relationship, as I mentioned, between forms of discrimination, specifically institutional and individual, and go into the details of the individual level discrimination measures. But what we found is that major discrimination was associated with preterm birth, and unadjusted models were not adjusted. We see that there's just sort of market increase, and major discrimination in this particular study was measured based on multiple forms or sources of discrimination, but also reasons. So it could be racial discrimination, gender discrimination, discrimination based on sexual orientation, et cetera. We found that women living in redline areas were less likely to have a preterm birth, specifically among Black women, which was actually opposite of what we expected. And so in our, some of our work moving forward, we're going to revisit this specific issue. So then the second level of racism is personally mediated racism. We think more so about interpersonal, right? I may have, been in a situation where I felt like I was discriminated against on an individual level based on, some treatment, right? And we think of prejudice and discrimination as an example. The ways in which we've measured this in previous studies or in current studies include the everyday measures of discrimination scale, experiences of discrimination scale, capturing interfaces with institutions, but also via audit studies. I don't have time to go into all the examples. There's multiple studies that look at, same credentials but different race, where there's differences in mortgage lending, differences in access to rental properties, the resume studies that found those who have quote-unquote ethnic names were less likely to be called back than those who had quote-unquote more European-sounding names. And then one of the most recent studies, the preschool study, which they used, this was more of a audit testing study where they used videos for teachers to identify behavioral, quote-unquote behavioral issues when there weren't any. So they were sort of a level of deception with that particular study. And all teachers actually were more likely to target behavioral issues in those videos among African American boys, although there was no difference in behavior in any of the children. So what about personally mediated racism in medical and healthcare? Just some other examples, right? So we have the medical discrimination studies, receiving differential treatment or medical care by race and gender when presenting with the same symptoms and conditions. So one example is the recommendations for cardiac catheterization, recommendations for IUD, right? Both finding racial differences in racial and gender differences for the first study, and then also economic and racial differences for the second study with relation to types of recommendations for those particular issues. And then also a myriad of studies related to experiences in healthcare settings by race and the context within that. And I just present a couple, but there's multiple. A more recent study by Monica McLemore, which uses qualitative work to explore healthcare experiences of pregnant and birthing women in California. And then a most recent study by a colleague and former student looking at African-American doulas here in Allegheny County. Personally mediated racism, again, just some additional examples. Some of the first work I actually conducted related to racism in health was around this issue of gendered racism. Really the intersections of gender and race as multiple forms of oppression that have an influence on pregnancy and birth outcomes. And what we found in this work is that stress and discrimination was very prominent in work environments, both in the survey that Jackson and Phillips conducted and some of the qualitative work that I did at the time as an undergraduate student, and then also stress and discrimination with respect to protecting and caring for children. And with that work, they actually continued on developing additional measures around capturing those forms of racism that aren't captured as much in other constructs. Some of you may be familiar with the September 11 studies. I'll just briefly mention the California-based study where they looked at, used an algorithm to determine people who had Arab names, and that was associated with a higher risk of both preterm birth and low birth weight, and even higher risk among women who actually named their children Arab names. The Michigan study actually did not find an association. And then finally, intersectionality in the weathering hypothesis. And this is a core element of the work that's being done within the areas of reproductive justice, specifically with relation to pregnancy and birth outcomes, that talks about the chronic exposure to stress as a result of multiple forms of oppression. So I mentioned the gendered racism, and we talk about race, class, and gender as core elements, and the physiologic load or allostatic load, if you will, from discrimination, stress over a lifetime, resulting in accelerated aging and adverse outcomes. And so this is just one example of the way in which Geronimus at the time wanted to apply that hypothesis to birth outcomes, where they found among white women, once again, a disparity between black and white women in low birth weight and very low birth weight, that among white women, sort of, if we look just at low birth weight between black and white women, sort of the optimal periods for pregnancy or improved outcomes or better outcomes were within the area, ages of 20 to 29, when in actuality among black women that increased over age, right? And this was adjusted for other core factors. We see a similar relationship here in our own county as well with birth record data, that with increasing age, there's actually a significant increase, right? And then finally, internalized racism. So this area of work is related to stigmatized races, believing the negative inferior characteristics or messages about their own group. I don't know of studies that specifically look at internalized racism with respect to pregnancy and birth outcomes. However, there's been some work on microaggressions and its relationship to self-identity and its potential influence on pregnancy and birth. So in the ongoing research and examples of works in progress, I'm grappling with some key questions, and I'll present just a little bit of work related to this. So one, how might racism and other isms be operating in this particular situation, right? And what are those implications for health? What are the interlocking systems of oppression? So how might systems of oppression get under the skin? And what are the unique experiences of, in this example, that I'll show, as well as the core elements of my work around the experiences of black women that may cause them to die or become sick more than other population groups. So once again, changing the narrative from sort of the individual focused blaming approach to what are the larger systems affecting those populations. And then finally, like, how do we measure some of these things in epidemiologic studies? Right. So the first example I wanted to talk about is my ongoing study called PMOMs. So this is the postpartum mother's mobile study. We know from previous data that showed you the disparity in pregnancy-related weight. And even with accounting with pregnancy-related weight, so pre-pregnancy weight, gestational weight gain, there's still a stark disparity in postpartum weight, right? So even when accounting for those other weight characteristics. Right? And so in this particular work, I'm combining, some of the prior work related to perinatal health with real-time data collection through ecological momentary assessment, with the primary purpose of understanding the applicability of EMA and understanding health-related measures, stress discrimination, weight, diet, physical activity, coupled with environmental-related factors that may influence, so social and built environment, and larger contexts as well. And then the secondary purpose is to identify key points during pregnancy and the postpartum period for potential approaches and interventions. Right. So some of the core elements and frameworks related to the work around racism and racial equity that I mentioned before is a particular focus and attention to racism as central in understanding the racial disparities in postpartum weight and cardiometabolic health. So applications of critical race theory and intersectionality, and then race as a marker for racism-related exposures. And then the underlying experiences of racism and stress when coupled with pregnancy could potentially send women on a trajectory of adverse outcomes during and after pregnancy. So PMOMs is a longitudinal study. It's ancillary to the GDM2 trial. This is a parallel arm comparative effectiveness trial comparing two strategies to assess and diagnose gestational diabetes. These are quote-unquote healthy pregnancies, so exclusions include pre-existing diabetes, diabetes diagnosed at less than 24 weeks gestation, multiple gestations, hypertension requiring medications, severe liver disease, and a few others. And women are recruited directly from McGee Hospital during pregnancy, as well as recruitment through other channels throughout the region. The criteria is that the women have to deliver at McGee to participate in the GDM2 trial. And PMOMs, we directly recruit from GDM2 during their first and second visits for those studies. And women are followed through 1 year postpartum. So I'm just going to briefly go through some elements of this. If there are more questions about the study and design, I can talk about those. So we started recruitment in December 2017, and as of about a week or so ago, we've consented 305 women, and 280 were issued devices or entered into our tech system, and I'll talk a little bit about that as well. So our main modality for data collection is via the mobile phone for PMOMs. Since it's coupled with an ongoing trial, we also use a variety of other methods for data collection. Ecological momentary assessment is our main sort of format and way in which we're identifying and assessing people's experiences in real time during pregnancy and throughout 1 year postpartum. Women receive a smartphone. They can either receive a smartphone from the study or use their own smartphone, and they complete surveys throughout the day. So they complete the beginning of day surveys, end of day surveys, random surveys throughout the day. And then we also pull in location through the GPS within their phone. So they have, you can see from the picture, they have the option to opt in or opt out. They receive a link through the PMOMs app, which directs them directly to the daily surveys that they complete. In addition, women receive a smart scale. It's a Nokia body cardio scale that we've used, and this is a scale that has been used in the POWER study, which was an exemplar study conducted by Laura Burke, as well as multiple studies that are attempting to measure weight over time. These are some of the EMA measures. So we have beginning of day measures about sleep, mood. Women are prompted to weigh themselves in context. End of day measures about sleep, mood, food, physical activity, breastfeeding, support, and context. And then the random assessments are some of the assessments in which we're specifically assessing stress, assess like 3 times in that same sentence, stress and racial discrimination. And I'll talk a little bit about those, as well as mood, depression, and context. So this is a screenshot of what the random assessment looks like, an example of the stress construct. Once again, we're attempting to measure these in real time as they're occurring. And these measures are really based or built on existing constructs. So for example, the Cohen Perceived Stress Scale is one particular scale that's been used to assess stress, however, has not been applied in the EMA context. So another core element of what we're doing is assessing these particular experiences in real time based on scales that are typical for a longer period of time, if you will. All right. So just based on just some of the population characteristics so far, and this is based on data that we gathered from the GDM2 trial in the fall. Obviously, we have, as I showed, more women in our population at this point. But based at, during that time point, we had about 23% of the women who were Black or African American, 64% were white, 60% had a college degree or higher, and then close to 60% were married. I just wanted to give you some examples of some of the EMA measurements that we're collecting and what this data looks like. So this includes all responses for all participants as of March, regardless of duration of the study. So this is not controlled for anything. This doesn't take into account duration in the study. But I just wanted to give you a sense and just a flavor or peek at what some of the things that we're attempting to collect. Right, so this doesn't also take into account average number of responses over a month and all of the ways in which we would kind of look at EMA data. So one of the first questions today, how often were you treated unfairly than other people because of your race? We asked about race and gender in this particular case. And then we have a follow-up question, how do you feel right now about that experience? So those who marked never, out of the 279 participants with data, we have 274 who marked never with a frequency of 40,000. So we have over 60,000 responses over the time period, and this is the mean and the range. If we were to look at the number of participants who actually identified that they experienced this at least one time that day, right? So again, it's asking today. That was a frequency of 119. And if we go up, a total of 9 people indicated experiencing unfair treatment because of their race at least 4 times in one day, right? So we'll continue to look at these measures over time. Then we also ask about gender, right? So if we look at the extreme here, 14 participants indicated experiencing more than 4 times in one day, some discrimination based on gender, right? And then we also include a scale of based on the racial and gender microaggression scale. And we ask about, did any of these things happen to you today? So once again, I'm just presenting the discrimination related variables. There's a multitude of other things that we're also collecting, right? Not just all the negative, but also things around support as well. So these are examples of the constructs that have been developed from the Lewis GRMS scale. And this is a few examples, right? So receive negative comments about the size of facial features, receive negative comments about skin tone, objectified based on physical features, felt unheard, tried to be put in place, have been told that they're too assertive, right? So all of these constructs relate to both the GRMS. And then the follow-up question, how did you feel at the time, and what did you do when it happened, and where was it? Right, so we're collecting additional information about larger contexts for those. So in addition to the EMA measurements, right, that are collected on a regular basis throughout the day, we also have non-EMA measures, right? These are measures that we're collecting at the beginning of the study, at the end of study, There are also measures that are parallel with core constructs that are being collected through the GDM2 trial, right? So one relates to major discrimination. And these are the core elements, some of the core elements within that major discrimination scale. And I mentioned that a little bit earlier from a previous study. So any time in your life, right, over your lifetime, have you been unfairly fired, not been hired, unfairly denied a promotion, unfairly stopped or searched, or moved into a neighborhood where neighbors made your life difficult for you and your family. So these are all of the constructs, but these are some of the key ones, right? And so out of those women who said yes, 17%, for example, for unfairly firing, the main reason they identified was because of their gender, and then 17% indicated because of their race. Right, so these are just 2 minutes, okay. So just briefly in summary, you know, within the scope of the PMOM study, our core, you know, aims and focus are to identify the determinants of racial disparities in postpartum weight and cardiometabolic health, understanding context, racism, and stress, applying novel measures of racism-related stress, as well as using mobile technology as a means to understand those experiences of women over time. And then just really briefly, other related work within this context, our neighborhood study, we're re-examining or revisiting the residential redlining study that I mentioned earlier, using birth records across the state of Pennsylvania and juxtaposing that with the HOPE maps, examining the relationship between mortgage discrimination, redlining, and maternal and infant outcomes. These are some other analyses that we're conducting in our larger research group, and then the Infant Mortality Collaborative that Nancy mentioned, and the PA Maternal Mortality Review Committee as well, are core ways in which I'm working both on the local level with respect to policy and intervention around addressing racism within the context of how we think about infant mortality in our county, but also the ways in which we review maternal deaths on the state level. And then finally, just next steps for public health and beyond. You know, it's really important that we continue to monitor race and look at different exposures around access and opportunities and outcomes. It's critical that we name racism as a potential force influencing all levels and ask, how is racism potentially operating here? Health inequities are complex and have a historical context and are intersectional, right? We think about race, class, and gender, and influence and mechanisms in our structures, policies, and practices. And then finally, we think about identifying what exists, but also what's lacking. Who's not at the table? What questions are we not asking, and why? I don't get into this. I do this usually with my class. We do self-reflection. So as a researcher, as a practitioner, interventionist, whatever, you know, sort of we're coming at this work within medical public health. It's critical that we do internal assessments. Like, how does your role relate to the populations and communities that you're interfacing with, and how does your power and privilege influence that as well? And then once again, achieving equity is beyond our current practice, right? So evidence-based is important but insufficient, as we see in the disparities, and that understanding social determinants of health are also critical but insufficient as well. And finally, all of this work is not possible without a team. So I'd like to obviously acknowledge the PMOM staff and co-investigators, a few who are in the room. Raise your hands, PMOM folks in the middle. Study participants, those involved in the Maternal Child Health Neighborhoods Project, organizational partners, and obviously the funding sources that make this possible. Thank you. Any questions? Yeah.
Thank you for that insightful and really interesting and important work. So I think there's some questions.
Here?
Yeah.
Thank you.
One thing I wanted to ask you is I saw recently, it was a journalism article, it was more like a Me Too angle. It was focused on like this disparities issues and outcomes related to pregnancy and reproductive health being like a re-traumatizing type incident. Are you asking about sexual or physical violence or something like that?
Not in the EMA, sorry. Not in the EMA data. In the GDM2, some of the core elements we do some of that we have the potential to pick up, but we don't have explicit questions related to that in our EMA assessment. Yeah.
So you mentioned Brazil and how that was a little bit different because we think about race in a little bit different way. How are people kind of researching race in that context where it's more mixed, more things, and how do you use it in simple things?
Great.
It's not as clear.
Great, yeah, great question. I'm actually learning about that. So I'm right now working with a group of scholars here in the United States as well as Brazil. And we're convening a meeting around APHA. So for those of you who want to come, we're convening a meeting to talk about that. So in these different contexts, the ways in which we, think about race, right? This concept of race and ethnicity. And you're from Brazil, I assume, right? So there's variation in the ways in which that's measured, right? Based on skin tone and the sort of variation within that. And Brazil, a lot of people don't know Brazil being, a nation outside of sort of the continent of Africa with the largest population of people of African descent, and anti-Black racism in Brazil as well, and how that affects health. So there's folks looking at it there, and I'm going through the process of learning a bit more about how they're measuring and assessing forms of race and racism with respect to health and well-being. Yeah.
Populations, specific Black populations, like for example the Caribbean Blacks, and their seemingly different outcomes, both economic outcomes and health outcomes, where they just seem to have just these really, in many terms, way better outcomes than their white counterparts.
Yeah. Yeah, they do. So the one slide I showed of those who are born in the U.S. versus those who are born elsewhere and birth outcomes, like we see that and replicated in multiple studies. And Jimmy Collins, he's done work in Illinois with the intergenerational sort of birth cohort. But it is critical that we also acknowledge within racial categories that there's variation, particularly as it relates to country of origin. And also sort of this conversation around, the larger context in the United States being toxic for people of color, and, growing up and being in a nation where that experience of racism and racial oppression does not exist, and then coming to a space where it does, and what that means for their health. Yeah. Yep.
What's struck me about that is that what you're really showing us is what daily life experiences. And I think sometimes when we're in an academic environment that these things may be socially less than they are in day-to-day life for people, but it's, I think, just really stunning to think about that. And I think it is a call for self-reflection and what we're like as a society. My question has to do with something entirely different. I understand that there is an effort to have ICD codes, International Classification of Disease codes for social determinants of health. And I wonder if you know much about that and if you think that's going to be helpful.
Great question. I don't know a lot of details about sort of the process for developing those codes. I do know that within, as you probably know as well, within the medical community specifically, that there's been a lot of work around how do we implement the measurement of these social determinants within, at least within medical records, so that practicing physician or clinician can use that in supporting or providing the best care for their patient. So there's been a large movement around that, but I'm not as familiar with specific codes that, yeah.
It's an interesting way, rather than to change access, because people still need to have access, and when people do have access, not to recognize that the care may be more complex.
Right. Right. Right.
I think it's an interesting idea, and I haven't wrapped my head around it, to link
Yeah, I know there's been a movement within Medicaid specifically, and I believe, I'm trying to remember the state, there's actually 2 states who've implemented reimbursement for housing within Medicaid. So if there's a housing security issue, there is some level of reimbursement. And these are sort of new policies that have been implemented in some states. Housing is a health issue, yeah. Mm-hmm. Oh, here, yeah. Oh, okay, who do I pick?
Cavalry's outside. I don't hear them today, so go ahead.
Okay.
Let me ask you about your unexpected finding about redlining.
Yeah.
So what are your thoughts? I know you
Oh, okay, last question, sorry.
The last question.
I can take more outside, but go ahead.
Did anyone have one?
Yeah, Jane was asking a question.
I asked about your thoughts on the redlining finding that was unexpected.
Yeah.
Had a lower percentage.
Yeah, among Black women. Yeah, I mean, so that was a tough one. Yeah, obviously unexpected. So we attempted to look at, just in ancillary analyses, the relationship between redlining and segregation, as well, to see kind of what were the patterns within this specific population. And what we found, so there's different ways that we can measure segregation with US Census data. One is sort of exposure. One measure is exposure. So to what degree are, on a sort of census tract level, for example, compared to the metropolitan tract, metropolitan area where people live, what is sort of the index for how much blacks might be exposed to whites, right? So we can do this with multiple racial categories using US Census data. And what we found was that those who lived in redline areas, so those that are areas that are more likely to have an applicant, so once again, this is separate data linked with the pregnancy cohort data, live in a census tract where the applicant was more likely to be denied, or the applicant would, there's a black-white disparity, sorry, I can't get my words out, more likely to be denied a loan, that they were actually less likely to be exposed to whites, so blacks less likely to be exposed to whites, which we expected would have been the opposite, in the same direction as some of the other segregation measures. We also looked at, sort of on an individual level, types of housing as well, and we saw some variation there. So we think there may be some elements that are specific to that population that may have affected why we saw sort of this opposite relationship, meaning that the sort of larger population lived in both social and private rental housing. So that could be a possibility. We could be seeing an effect of, a protective effect, if you will, as we talk about segregation and enclaves as it relates to birth outcomes. So there's several explanations we're kind of considering with our new study and our additional analyses.
I'm sorry.
Yep.
Thank you very, very much.
Yeah, thank you.